Hello there, I'm Dr. Brad Mouroux, Spine Injury Medical Center. I'm here with Russell Pate. He's the shoe doctor. He's a Pedorthist, and he shares some time in our office. And I thought what he does is really interesting. He works with insoles and inserts for the feet, like orthotics, and it's a unique approach. He's a Pedorthist, and most people probably have never heard of a Pedorthist and how it's different than a podiatrist, but I thought like the spine is the foundation for the health and the movement of the body. The feet are also part of that foundation for movement and how it can affect the spine, amongst many other things, but also the pelvis and the health of the feet have a great deal of impact on the health of the spine. So I generally view Russ as a good teammate in overall health care and rehabilitation for musculoskeletal injuries. But Russell, that's enough of me talking. I know that people will probably want to know more about what is a Pedorthist. What do you do?
So I'm not a doctor. I'm certified an orthotist, and I can actually do braces and different things. But I've really taken my practice just to specialize in orthotics.
Okay.
And there's obviously, chiropractors do orthotics, podiatrists do orthotics.
Yeah.
I tell people that's all I do. I've been doing it for 25 years, and so I'm pretty good at it.
Really?
And so, and I've kind of developed, I originally started doing casting and foam box. And
oh yes, the foam box ones, you put your foot in there, it molds to your foot, and you get an impression.
Right. Yeah.
Right.
So I originally started doing that, and then when the computer came out, like 25 years ago, I saw it's like this, computer generated is so much better. It's kind of like comparing a computer to a typewriter. And so people really can appreciate the differences, and it really surprises me, Dr. Brad, that how many people are still doing casting and foam box.
Yeah, actually, in the chiropractic field, it's still, they have the flat glass scanners, but they still, have us use the molds, and that's been, standard for over 20 years. But as I understand it, there's better technology out there, and there's better use of that technology, and the computers, what I meant, in more three-dimensional contouring and imaging. But first, what is the difference for everyone? What is the difference between a Pedorthist and a podiatrist?
Okay, so podiatrist is a doctor.
Right. They
can do surgery and administer drugs and that type of thing. I don't do any of that. Thing is that I tell people is that all I do is orthotics. That's all I do every day, and so I'm much better at it than a chiropractor or a podiatrist who does one or two a month. And so I see a lot more, and I actually have a fair amount of chiropractors, you being one of them, that refer to me. And I have a few podiatrists that even refer to me, because most podiatrists really, I tease a little bit, want to be orthopedic surgeons, and really the money is really in surgery. And so, but most people, it's kind of like with you want to kind of avoid surgery most of the times at all costs. I mean, you can always do surgery, you can't undo surgery.
The whole reason why chiropractors exist is to help people avoid surgery. So, not to mention just to help function better, but in general, philosophically, also the difference, what I found is that Pedorthists or chiropractors actually have a very similar basic sort of philosophy. Like what we're trying to do, correct me if I'm wrong, is that we are trying to do, for you it's an orthotic, but I'm trying to do a therapy in order to improve function.
Correct.
Not just support dysfunction or support a problem, but to improve function.
Correct.
And that is the purpose of your methodology and your orthotics, is that right?
Yeah, so how I like it, and I think both of us do that, is it's really treating the symptom. It's getting down to the root cause, and I think that's why you and I work so well together, is because that's both our goal, is getting down the root cause, and then we can, our patients really benefit long term. It's not a short term gain.
How are your orthotics? Let's start with that.
Okay.
How are they different than like a Dr. Scholl's, or like the mold we just talked about, or going to a running store and having your foot scanned in the running store? What are they doing versus what you're doing? We were talking about accommodative orthotics versus functional or corrective orthotics, right?
So the first thing that you need to be able to understand is, so a foot is a tripod, so you've got heel, big toe, little toe. So the heel to big toe, that's the arch everyone ever talks about. You've got the second arch that goes from the big toe over to the little toe, that's the transverse arch, and then you've got the lateral arch that goes here. So you really, orthotics proper, in my humble opinion, you want to support all three arches.
Okay.
Most orthotics that are made are only supporting the big toe arch. Okay,
right.
And most of them are what you're saying is accommodate, which is cushion. And so it's like a difference between a pillow where you're just stepping in the pillow and it just forms, it's kind of a free form. So if you have a flat foot and then you step on a pillow, it'll give you a little cushion, but you're not really changing the function. The other side of that is there's orthotics that are hard plastic, and that's very, very common when a lot of the castings are hard plastic. So then you're getting what's called a functional orthotics, which is very hard. It can be uncomfortable because if you have someone that's flat-footed and all of a sudden now you're kind of lifting them up, it's kind of like stepping on a rock. It doesn't really give you that. There's no give. And so what mine do is kind of the best of both worlds is, first we're going in and we're doing a 3D foot scan and being able to support all three of the arches. But it's kind of like a firm mattress with a pillow top. Then you're being able to really support all three arches and support the foot. This is EVA. So this is EVA and it's different densities, which is also a little bit unusual. So this is EVA is the white material that the shoes are made, but this is a very high quality EVA.
And looks like definitely more dense over here and a little bit more softer over here.
Correct.
More to the accommodative give.
And so I have people come in every 6 months.
So you're looking to see change in the foot, in the position of the foot within 6 months of starting the orthotics here.
Correct.
Wow, okay.
Which is very unusual. They're normally, making orthotics. First, I need to back up just a little bit, is that people, when you're using foam box or you're using casting, you're making an impression of the foot in the position it's already in. In my opinion, we've really been making orthotics wrong for years. It's no difference than, you ever have braces on your teeth? And I'm sure your parents wouldn't have paid the orthodontist to keep the teeth in your same position.
Yeah, that'd be a waste of money, right?
Right, yeah, but that's what we've been doing with orthotics for decades.
So yeah, we're just making this cushioning softer, but we're not really changing the function or the way, like the dysfunction's still there. You're just making the landing a little nicer on your foot, but eventually it'll still come up with the same sores, same problems. It'll just take longer before you feel it, right?
Right.
Tell me a little bit more about what's happening with the methodized, what's happening with those pegs that are going up to the feet. Tell us a little bit more as we're doing the scan, what we're looking for.
Okay, so first we start out with the standing scan. What we're doing is trying to get the position of the foot, and then we've got 500 pegs coming up underneath the foot, and capturing every quarter inch there's a peg. And so what you end up with is this 3D mapping of the foot. And so then you end up with a digital map of the foot, the pressure points of the foot, as well as a 3D image. So then we do a sitting scan. So it's the difference is that people who have healthy feet, there should be little or no difference between the standing and sitting scans.
Now, what normally is assumed to be the reason for the difference in the two, like ligament damage or muscle failure, or what?
Ligaments, muscles collapsing. I call it more just collapsing of the arch, just to kind of encompass. As the chiropractor, the feet are the foundation, and so if the ankles, the knees, the hips, the back,
all of it starts getting infected all the way up to, definitely at least up to the hips into the lower back, because you expend more energy when your arches are falling.
Correct.
So if you're a sports person or you're a runner or whatever, you're losing a ton of energy if your arches fail. Let's take a quick look at these scans.
Well, let's start out with the sitting. So ideally what you want to have a little bit of red on the heel and weight on the big toe. Most of the pressure, even though I say the foot is a tripod, it's really more like a bipod with a kickstand, with the little toe being the kickstand. So most of the weight should be on the heel and on the big toe, and when that proper distribution is done there, you end up with a fairly straight line between the medial and the lateral arches, And that's what we want to have. And so if we go, and I do have athletes, regular everyday people that when they go to stand up, their foot doesn't collapse. And so if it doesn't, it's a little bit like kind of going to the dentist.
You don't need the orthotic.
Yeah, you don't need any fillings.
Fillings, right?
Yeah, but it's worth getting it checked because you want to catch it at a cavity and not wait till it's a root canal.
Right. You don't want to wait till your arches are fully fallen or bunions start to form and things like this, because you can prevent those things. Just so that we're looking at it, when we're looking at the before picture, this is an example of my foot which has more pressure on the outside arch where the red is and versus the inside where it should be. So the primary arches should be loaded more. Where the green is, it should be more red, and right here where the red is, it should be more green.
Correct.
And then the correction side we can see. And then there's also a three-dimensional sort of visual, like computer visual aid of what the orthotic would look like.
Correct, yeah. So I can actually take people that already have orthotics and come in and we can actually compare what my orthotics would look like compared to what they already have. Because some people say, well, I've already got orthotics, and it's like, well, you may, but you probably aren't getting support for the little toe side. Rarely do I see orthotics that support the heel to the little toe side. And and in here, I would actually even add a little bit more lift between the big toe and the little toe to get that metatarsal, lift in your foot as well.
Wow. So we're trying to keep these things short enough so they're digestible. There's plenty more, of course, that you could get into, but fundamentally, the reason why I want Russ to talk a little bit more about this is the difference of the approach. We're both focused on functional recovery. That's very much in line with what I see our practice doing from the ground up. What we're trying to do is look at root cause, help improve function, and give support where there's failure to help get the body back to a level of function that it didn't have. Can we restore 100% function? Typically, no, right? Typically not 100%. But if you can get majority function back, you're experiencing a level of function back in life that you probably haven't experienced since you were a kid, literally.
Right.
So the differences in feeling, changes in energy level, all are big. They're huge. So that's why I appreciate the way you guys approach things. I mean, we're not looking at putting Band-Aids, we're looking at making fixes.
Right.
Just so you guys know, there's no direct compensation affiliation between us. He's renting space at our office, and he has a location over in Dublin in Cooper Sports. It's more of I just want to be a synergist to help people find connections for good people, good doctors, good practices, and good therapies, orthotics, good methods to help people recover functionally. The less we depend on drugs and therapy, the more we can help you fundamentally bring your balance and function back to your life.